So let's get to some of the questions. All right, this is a very good question. This says, I'll give this to Dr. Wolin. How important is pancreastatin as a marker, and what does it mean when it's elevated? So we didn't really talk too much about tumor markers and how they're used in diagnostic areas as well as monitoring our patients. Do you want to briefly address that, Dr. Wolin?
Chromogranin is made by neuroendocrine cancers, and typically it's made along with whatever other kinds of hormones might be made by the tumor. It's a very, very good marker under certain circumstances. The problem is there are many, many things that make chromogranin elevated that are completely unrelated to cancer, such as taking antacid medications, which are exceedingly common in the population. People use Protonics, Prevacid, Zantac, all kinds of things. And if you take those kind of medications, chromogranin can be very high without having anything to do with cancer, and it's of no consequence. People have atrophic gastritis, it makes chromogranin high. People have problems with kidneys function, makes chromogranin high. So it's not terribly sensitive, and it's influenced by a lot of things. Pancreastatin is part of the same molecule as chromogranin A, but it doesn't have those same false positives. So it's a very good test. It's a very sensitive, accurate test. It's a little bit more difficult to do. It's only done in a few laboratories in the country, but I tend to check both. I use pancreastatin all the time, and in several places around the country, people use it frequently. Chromogranin nationally is more commonly used by itself, but I think pancreastatin is a good marker. What I have to tell you, though, is if cancer is growing on X-ray, it doesn't matter what the chromogranin or pancreastatin are showing. If your cancer is getting bigger, it's getting bigger. And if it's getting smaller, it's getting smaller. But these types of markers are sometimes useful. If there's no detectable cancer in the body, everything's been surgically removed, or you haven't ever had a recurrence detected, if these numbers become very high, you might become worried. Also, one more thing to know is that every laboratory that does those particular tests has different values for normal. And they could be enormously different from one laboratory to the other. In one laboratory, normal could be several hundred. Another laboratory, chromogranin could be less than 15 to be called normal. So you can't compare one laboratory with the other. It's a little confusing.
Yeah, also University of Iowa has published a paper talk about pancreastatin. They use a pancreastatin, certain numbers are cut off to decide the tumor biology, which number you're okay, which number you're bad. We tried to duplicate the same study. However, in our group, we did not find that helpful. But they did write a paper, talk about pancreastatin can use as a tumor biology predictor.
Yeah, and I just want to make one more comment. Ed, CGA is not, it's affected mostly by, it's not affected as much by the histamine blockers.
Correct. It's affected more by PPIs.
Yeah. So
correct.
Patients that are on PPIs, such as Nexium and Protonics, needs to be stopped, and patients need to be switched over to Tagamet or Zantac before the test is done.
Yeah, if it's going to make a clinical difference in the
Right.
result.
If it's not going to make a clinical difference, there's no point in doing it. Okay. So another question on markers, and it's addressing Ki-67. If there was no Ki-67 done at the initial biopsy or resection of the tumor, is there a way to still find this years later? So really the question is, can you go back to the original block and get some information? And what information can you get from the original surgical block? It's called a paraffin block from the original surgery. Or does a patient have to be rebiopsied to get some information? Or does the Ki-67 change, and should a rebiopsy be done after many years? You want to address that, Dr.
In my practice, I must look at Ki-67 because I run the opinion. With my limited experience, more than 800 cases now, anyone with a Ki-67 20 or 25 or higher, I call that one first, because those patients really not good surgical candidate. Even I show you all the slide, I love to do surgery. I'm crazy to do, debulk surgery, all kind of thing. But the patient's selection is very important. If someone with a Ki-67 that high, 25 or above, really, the medical therapy should come as a primary role, and we really don't have much, to offer. So I almost never tell patients, say, yes, I can help you until I see the Ki-67. So for those patients come from some other state, they don't have that, I will tell them that you need to sign a consent. We will have your pathology lab send all your tissue, including the original slide and paraffin wax, all the stuff, sent to my pathology lab, and my pathology restain them, and then give me a report. Then I can make a decision based on that.
So we got 2 important points out of that answer. Number one, Dr. Wang doesn't operate on everybody that knocks on his door.
No.
He's selective, and the tumors with a high Ki-67, the very aggressive tumors, are better addressed with other modalities first, and maybe debulking later. And second, the Ki-67, just like many other pathological stains that are done to make the diagnosis of neuroendocrine tumors, those tests can be done later on a paraffin block, so you don't have to have fresh tissue for that. And do you know if Ki-67 changes?
Ki-67 definitely changes, and over the course of many years, often becomes a little bit higher, and the tumor becomes a bit more aggressive than it was. Ki-67 is a measure of the percent of the cancer cells which are undergoing cell division. So it's an indicator of cancer aggressiveness. And the cancers are divided into low grade or intermediate grade or high grade based on that number. The Ki-67 is very heterogeneous, and it's very confusing. In a tumor, if you really look hard, you could find areas that are very low and areas where the Ki-67 is higher. And it can be mixed in the same tumor. And you can also have metastases with one Ki-67 and a primary with another. So even though some people are just totally fixated on the number, it's not as important as thinking about it as just one part of a whole picture. You have to see how fast the cancer is really growing in real life, and how much is, how aggressive. So it's another piece of information.
Right, there's a slide that I showed in the beginning of a tumor grade, and there were 2 items on this, that were listed on there. Two of the items that were listed on there was Ki-67 and number of mitoses per high power field. And they kind of go hand in hand, but as Ed said, they can be heterogeneous, and it depends where you look at. So number of mitoses is the pathologist actually looks at the slide and counts how many cells are actively dividing in a particular high power field. Just like in the Ki-67, the pathologist is looking at it and determining a percentage of cells that are dividing. And one interesting note is that traditionally in medical oncology, cancers that grow rapidly, that are cancers with a higher percentage of cells that are in the dividing phase, the rapidly growing phase, those cells are more sensitive to traditional chemotherapy, cytotoxic chemotherapy, because those drugs target cells that are actively dividing. Okay, so those really aggressive cancers may be more susceptible to chemotherapy. Okay. Next question. Question for Dr. Wolin. How is the decision made for a patient to have Sandostatin versus lanreotide? And after a decision is made, if one seems to lose effectiveness, would the other be tried?
Good question. In the United States right now, the FDA has approved lanreotide for the treatment of neuroendocrine cancers of the intestinal tract and pancreas, and that's a standard treatment which is approved. Octreotide or Sandostatin has only been approved for treating diarrhea and flushing associated with carcinoid syndrome, but it's never been approved for treating cancer. So in principle, either drug could work for both things, but the convincing data that led to the FDA approvals are what I just told you. Everybody who has carcinoid syndrome also has carcinoid cancer. And usually the other way around, not always the other way around. You can have carcinoid cancer without a syndrome. So I think that it depends a little bit on people's insurance plans It depends on whether they're already on a medication which is working, because they both do pretty much the same thing. If you've been on octreotide and it's working, I wouldn't switch to lanreotide. But if you're a brand new patient who's being diagnosed and starting on a new drug, the approved drug is lanreotide at this point. Lanreotide theoretically has a couple of advantages. Number one, it's a subcutaneous injection instead of intramuscular. Number two, if people are obese and you get an intramuscular intended injection of octreotide and it ends up in the fat, what can happen is that you have a very poor blood level that month and your symptoms can get a lot worse. So you have more erratic blood levels. So for people that have problems with obesity, you're better off with lanreotide. The other problem is in people that have some malnutrition and they've lost weight and they're very thin, and they don't have a big rear to inject octreotide into. You're way better off having a subcutaneous injection with a short needle. And lanreotide would be the drug in that circumstance. So I think it depends on just the discussion with the patient and the oncologist. They both do very similar things. Now, we've seen anecdotally cases where people were first on one drug and then switched to the other, and it seemed to control the cancer. But there really isn't a single paper in the world literature proving that that's an effective treatment thing to do. But I think that it's also something that is relatively free of toxicity, and you haven't really lost anything by doing that. So if somebody's on octreotide and the cancer starts growing, it's unlikely you're going to have a major response to lanreotide, but you're not going to hurt anything by trying. And even doubling the dose of octreotide doesn't make that much difference. You saw in the NETTER-1 trial, when patients progressed on octreotide and they had doubled the dose of octreotide and went to 60 milligrams, by 8 months the tumors were having major progression on X-ray. So
Right.
you don't get that much mileage out of the increased dose.
Increasing the dose is more beneficial for controlling symptoms than controlling cancer progression. So that would be an indication to increase the dose, but not cancer progression. For me, the two drugs are pretty much interchangeable. There isn't the insurance problem with occasional patients. Interestingly, I've had a patient with a PNET, pancreatic neuroendocrine tumor, where lanreotide is the approved drug, and the insurance company would only approve the Statin, and I had to educate them on which was the proper drug to use. So you run into issues, all kinds of crazy issues. As far as comfort for the injection, Ed made some really good points, but it runs both ways because the volume on the lanreotide is larger than the Statin, so the sub-Q injection, although it's sub-Q, it can also be a little bit discomfort and can last a little bit longer as well. So it runs both ways.
Just one more comment. Lanreotide is not available except in a long-acting injection every 4 weeks. So when people are having anesthesia, people are having procedures, and you need a medication for preventing or treating carcinoid crisis, intravenous octreotide is the only way to go. If you have to use octreotide, you can't use lanreotide in that circumstance, and be aware that that is a complication of anesthesia, and it's a complication of manipulating the liver. Angiography, liver-directed therapy with embolization, surgery. Just realize that you need extra octreotide to prevent problems with carcinoid syndrome causing carcinoid crisis.
Okay, let me have a question for Dr. Wang, and then we'll come back to a couple of questions on the SSAs. Dr. Wang, question is, do Chinese dumplings disintegrate?
Yes, the basic material called gel foam, by manufactured inserts, those dissolve in 6 weeks. With chemotherapy mixed into it, I think the macrophages, the normal cell to eat up the gel foam, maybe delayed, because I have many patients 3 months, 4 months after the fact get a CAT scan and see something funny on the CAT scan. I tell my patient, don't get anyone scan you for the next 5 months, because I have so many patients went to some hospital out of state, get a scan, and the radiology called the Chinese dumpling abscess, and they put a needle and they suck it up, and drive me crazy because the whole point I put a Chinese dumpling there to prevent cancer from coming back, and they think that's an infection. They put a needle and they suck it up. So I told my patient, don't get scanned for the next 5 months unless they talk to me first.
So next question I'm going to start with, and we'll go on from there. The question is, if you're doing well on octreotide for more than 8 years and there's no apparent progression, does it pay to try some of the new treatments or experimental treatments? Does it pay to take a gallium-68 net spot test? So let me just start by saying, making a point that as Dr. Wolin mentioned, most of the cancers that we're dealing with NET patients are slow-growing, chronic diseases with a pretty long life expectancy, and many of our treatments are geared to what I call resetting the clock. Okay, we want to bring our patients' tumors under control, and for long periods of time. If the tumor starts progressing, we want to reset the clock again, okay? And we've done this approach with other cancers as well, multiple myeloma is one, things like that. So we want to continuously reset the clock. We can reset the clock by surgery, by debulking. We can reset the clock by radioembolization or bland embolization. We can reset the clock by some of the medications that we use, whether it be CAP-10 oral chemotherapy or Afinitor, or whatever, but we constantly want to reset the clock. So if you're doing well and there's no apparent progression, I personally don't see a need, if you're being followed appropriately by your medical oncologist and you have your periodic MRI and everything looks copacetic and everything looks fine, I don't really see a need to go ahead and be aggressive unless the findings are different. Ed?
I completely agree. Get as much mileage out of somatostatin analogs as possible. It has very few side effects in most people and can work for years. If you stop it, cancer can grow. Just keep the medication going. As long as you have somatostatin receptors in your tumor, you can prevent those cells from growing for a long, long time. It's a little bit like using anti-estrogen in breast cancer or anti-testosterone medicines in prostate cancer. If you stop those medicines, even after many years, the cancer will start growing more. So I would be in favor of continuing and don't rock the boat if it's working.
So another question was, are the new medicines octreotide-based or contain octreotide? Really, that's not the question. The question really should be exactly what Dr. Wolin just said. No matter what else you need to take in the future, if the cancer shows progression, you need to stay on the SSAs.
That's the general recommendation. The only time that you make a little change is if you're getting PRRT, you have a modification during that time because you don't want to have PRRT at the same time as you're taking an SSA. But there are ways around that where you stop right before each treatment.
Okay, so Dr. Wolin briefly mentioned that there are not not any terrible side effects to the SSA, so let me just address that for a second. Some of the side effects that we do see and we try to prevent are B12 deficiency and malabsorption of some vitamins. So I personally give all my patients a B12 shot when they come in. And thyroid function can deteriorate, so I do check the thyroid function every 3 months. Okay, and the other question was flatulence and development of diarrhea while you're on the sandostatin, which may not necessarily be progression of disease or ineffectiveness of the sandostatin. It may be due to malabsorption. So we do use some enzyme therapy with that, sometimes Creon, things like that can help. Dr. Wolin, do you want to address that as well?
It's really very, very important. There are patients that are having such bad problems with malabsorption that they are unable even to get out of their house, and that can be fixed by using pancreatic enzymes. One of the side effects of octreotide and lanreotide is that your pancreas will produce less digestive juices, and you can't digest food properly. So if you don't have pancreatic lipase and you eat a piece of pizza, you're not going to digest the cheese. The undigested cheese then goes on into your colon, and the bacteria in the colon will ferment it and make a whole lot of gas. And you'll turn into a gas factory that's causing a lot of bloating and passing gas, and it'll ruin your whole day. And that can be completely prevented by using pancreatic enzymes prior to eating that pizza, and you won't have a problem. So I think if anybody is having these kind of GI side effects, definitely talk to your oncologist about it and consider optimizing a program of pancreatic enzyme supplementation. These are just nutritional supplements. They're not even really medicines. It's just natural pancreatic enzymes. But if you don't have enough of them and you need more, it's just as important as using lactate. If you can't drink milk because of lactose intolerance, it's the same idea.
Okay. Just one question I'm going to address and we'll go on. We briefly mentioned whether or not receptors are permanent or they change, and this was basically a question on octreotide or octrea scan. And if once you have a positive octrea scan, is it always going to be positive? So let me just tell you my approach to, we'll see if Dr. Wallens is any different, for following patients with octrea scan. I use the octrea scan in the beginning when I first see a patient, if it's not already done, to see if there's SSA-avid disease that we can use our either lanreotide or sandostatin on. I generally don't order another octrea scan to follow my patients over the years, except in certain circumstances. So to follow a patient, I'll use the tumor markers, I'll use the MRIs. I like MRIs better than CAT scans unless there's a contraindication, to follow the disease and see if the tumors are stable or growing on whatever treatment they're on. But I generally won't do another nuclear scan unless there's progression of disease and I need to know if any new findings on MRI are also octrea scan positive. And so that's basically the only, or if I get a complete resolution of disease on a particular treatment and the MRI becomes negative, I'll do another scan to see if there's any residual disease that I'm not picking up on the MRI. That may be replaced by a gallium at some point. But those are that's how I do it. So that's how I follow my patients. Do you do anything different than that?
I think mostly the same, just a few little modifications. I agree that you do somatostatin receptor imaging at diagnosis to find out if somatostatin analogs will be likely to work. And you do it again if it's going to change management, okay? So if it's going to make a difference in determining if some finding on an MRI is cancer or not cancer, if you know it's has somatostatin receptors and it's likely to be positive, if it's there, you can get a scan. If somebody is thinking about having PRRT, you get a scan, you find out if the receptors are there on all the tumors. Usually if you start off with having a positive scan, you continue to have a positive scan if you continue to have tumors. But it is possible to have some mutation in a clone somewhere that is negative, and in those people, PRRT would not be as useful, so it is important. However, I don't order octrea scans really much at all anymore because gallium dotatate scanning is just so much more sensitive. On an octrea scan, the smallest tumor that you could see is usually 1.5 centimeters in diameter. So if you don't see a tumor on the MRI, the chances are really, really tiny that you'll ever find it on a octrea scan. So normally I don't even use it for that purpose. It's just not a very sensitive test. On a gallium-68 dotatate scan, you could find tumors that are a couple of millimeters in size, just little teeny-weeny tumors. And that's a much more useful test. And I think we're going to find it's going to replace the octrea scan. But I really agree with what's been said. I don't believe in doing them over and over and over and over just to find out that it's positive or negative. It's not going to change results in anything you do. I believe for any test that any doctor does for anything, you should only do it if you're going to do something with the result. If you're just doing it for fun, it doesn't add anything. It's not worth it. And I think that's the case with these scans as well.
Okay, a couple of questions on oh, sorry.
I do use a octrea scan occasionally, especially for the patient I have to redo surgery because as a surgeon, one of the problems in the operating room we have to deal with is, are you dealing with a tumor or dealing with scar tissue? And both looks are wide, both like firm. And a lot of time without any help, we'll waste a lot of time and energy and dig into the area which should not be in there. So I find out with my octreotide injection ahead of the surgery and then use a handheld Geiger counter in the operating room is such a blasting tool to select my effort in the area where the money is. And when I scan the white stuff, it's don't beep. I know the decoy, something beep, it is a real McCoy. I have to chase it. So I don't waste my time digging around everywhere. And by doing that, I reduce the blood loss, reduce the operating time, and also reduce the complication.
Right,
That's
and that's the reason, excuse me,
That's a good point. That would change therapy. So
that would change therapy. And I think nowadays, anytime anybody is about to go to surgery, whenever possible, to get a gallium-68 PET is really the ideal, because that, for exactly the reason that Dr. Wang is saying, it'll help you so much with surgery, and it's going to help you even more if you have a high-resolution test where you can count on the results and it's not blurry and equivocal in so many places. Agree?
Agree.
Okay.
So the fusion scan, you can have the gallium-68 fix it with a CT, or you can know precisely where the money is.
Okay, we have 3 questions on eligibility for PRRT. So let me just run through them quickly so you can address the points. One question was, if a patient's had palliative radiation for bone metastases, would that change eligibility for PRRT? For example, would bone marrow suppression be a factor? Another question, let me give you them all so you can address them at once. Can a therapy like PRRT, CERT spheres, CAPTEM, etc., be used more than once? Again, we're probably talking about bone marrow suppression. And after successful PRRT, does a patient typically need any other chemo? Well, I hope not if it's successful. And or Sandostatin analog therapy, and that we already addressed, that the patient should go back on the Sandostatin analog. But the other questions you can.
Okay. If people have more than about 25% of the bone marrow in their body treated with radiation therapy, it makes PRRT more dangerous for the reasons that we're hearing. And you can have worse drop in your blood counts, and it can be much harder for blood counts to recover. Normally for carcinoid tumors, you don't really get that much radiation to that much of your body. But if people really have had very extensive radiation, if their whole pelvis needed to get radiated for some massive tumor, I mean, you can imagine some kind of a situation or some other malignancy they might have had in the past, but that's really very unusual. For normal radiation people have had, it doesn't make a difference, okay? And it's okay to do that. One of the things we worry about with PRRT, it's very, very rare, but maybe 1% of the time you can actually get a bone marrow injury that doesn't recover, and it can lead to pre-leukemia or leukemia. But again, that's less than 1% of the time, and it's not something that happens very often. But whether that would be a bigger problem also if people have already had a lot of radiation injury to their bone marrow is not known. But theoretically, that can contribute to that. So more than 25% of the bone marrow, no, that's the cutoff. And the second question was about using other kinds of therapy after PRRT. PRRT doesn't really close doors to any of these other kinds of modalities, and we can use immunotherapy, we can use CAPTEM, we can use, everolimus. Any of these things could be used after PRRT. The exact place that PRRT should fit into the equation is still being worked out, and whether you should have PRRT first or embolization of the liver first, there's a controversy about it. In Europe, where they have been doing a lot of PRRT for a long time, they do PRRT before they do embolization, because that way you have a really good blood supply to everywhere in your liver, and they feel that maybe that's the best time to do it, and then follow that with embolization. But certainly we've done PRRT in people who have had embolization. You'll hear a lot more about embolization later. Radioembolization is a little bit more problematic. PRRT can be done after radioembolization, but it probably causes a little bit more risk of liver injury from PRRT. But all the other kinds of chemotherapy can still be done.
Just a comment for my patients that have had symptomatic bone metastases, which is not very common in neuroendocrine tumors. I've actually successfully treated all of them with bisphosphonate therapy, zoledronic acid, rather than using external beam radiation. I've had very good results with controlling their pain.
Yes, I do that as well, or Xgeva.
So last question. and this is, I guess we need our team approach on this one. A patient with liver mets treated with 6 rounds of chemo has an unknown primary, undiagnosed primary. What would you recommend at this point? We don't have any other information on if the patient's on sandostatin analogs or what chemo it was or where besides the liver metastases, where else it is. So I don't know if the patient, how would you approach this patient, Dr. Wang? How would you determine if this patient would be suitable for surgery at this point?
My patient selection criteria, I do look at all the CAT scan, the pathology report, everything else. As I said, if someone with a Ki-67 high enough, I consider high-grade tumor, I never even touch those patients. I tell them, you'd better run for your life away from me because I'm going to hurt you more than helping you. If they are the low-grade tumor, 1 to 2%, I will look at then the scan. The scan, basically, I'm just looking and say what I'm dealing with. I'm going to China, or I'm going to Europe, or I'm going to Asia, to Japan. But I never cannot decline anyone's surgery based on the CAT scan result, because as I showed you, most of my patients, 78% of patients get demand resected already. And the CAT scan looks terrible. Everyone gave up on those patients. I go in there, I did it anyway. On the other side of the coin, I have a few patients look at CAT scan, looks like a chip shot. I go in there, I was asking for mercy because it was not easy at all. So I'm no longer making decision on the scan result. The most important criteria is patient healthy enough to go through general anesthetic without giving a heart attack or stroke on the table, and their nutrition sound enough to heal the wound. Doesn't matter how good the surgery I do, if they don't have the nutrition to heal the wounds, I'm not going to be able to help them.
So the reason I called on Dr. Wang first to answer this question is because as if I were the captain of this ship, my first approach would be to, and I'm inheriting this patient at this point in time, I need more information. I need to find out what the Ki-67 is. I need to find out the extent of the disease in the liver and outside the liver. I need to look at the pathology. I need to look at what the patient's been treated with. And most important, as Dr. Wang said, I need to know the patient's performance status. That's what we call their general state of health, to see if it's okay to be aggressive with this patient. And I would consult with Dr. Wang and see if surgery is a feasible option. Why wasn't it entertained in the beginning? Was there a reason it wasn't entertained in the beginning? Is it a feasible option at this point? Barring that, I would go down and talk to my other members of the team and talk to my PRRT man, my interventional radiologist, et cetera. How would you approach that, Dr. Wang?
When you have an unknown primary, it really depends on how you define that concept. Unknown primary means when you have CAT scans, MRI scans, upper GI endoscopy, colonoscopy, even wireless capsule endoscopy, you swallow a little pill cam, endoscopic ultrasound of the pancreas, all kinds of tests, everything that people could think of, and you don't know where the primary is, you call it an unknown primary. We did a study at Cedars-Sinai with unknown primaries, okay? And we were able to identify 85% of the time in that same population of patients, 85% of the time, we found the primary using double balloon push enteroscopy, and we found the primary in the small intestine. The smallest was 1 millimeter across, and several of them were less than 5 millimeters across. And they just were not causing any problems, and people didn't know. There were some patients had lots of tumors in the small intestine that were all over the place, and they still didn't show up on any of the scans. So the most likely place is going to be small intestine in that population, because it's pretty hard for a pancreatic primary to escape getting detected by all of those things. So bottom line, if somebody has an unknown primary and it's going to make a difference in their management in terms of what's going to be done, okay, you could find it by things like small bowel endoscopy, like I just mentioned. You could find it by doing gallium-68 dotatate PET-CAT that can find unknown primaries in many cases. Sometimes they're never found except at surgery, where they're just incidentally found at surgery. But you can often tell by features on the pathology. There are different specialized stains. CDX2 is often positive in small intestine carcinoids, for example, and we have some different tests that can be done to help identify a primary. And there are certain tests, like there's a company called Biotheranostics that does a whole panel of molecular tests to try to figure out where it might have come from. Sometimes that will give a clue. Sometimes it makes absolutely no difference at all because management is the same. If you presume that a cancer is midgut based on presumptive evidence, that patient is allowed to be treated with PRRT, even on clinical trial, even on NETR1. Those patients could be treated, so it doesn't even make a clinical difference in management. So you have to put it all together in individual cases.
If the patient has a very predominant disease in the liver, especially with a large lesion in the liver, and I think surgically I can debulk it, and also there are a lot of lymph node disease in the abdomen, has not have any previous treatment yet. I usually recommend surgery because I can debulk the liver, I can remove all the lymph nodes, the mesentery, and at the same time, almost 100% of the time we'll find the primary and remove it all at one setting. And people ask me, say, why you bother to even do a liver surgery if someone a lot of disease in there and just take out the big dominant tumor? And I tell them, say, the easiest thing to understand, if you 100 kids, you have $100 in your pocket, you want to give your kids money, every kid get $1. If you kill the 90 kids, only have 10 kids left, now you give it $100, each kid get $10. So that the medical therapy will be more effective if you have less tumor burden in your system.
Well, it's another colorful way of saying resetting the clock. But the interesting point and that we want to make here is that we do come across patients that are presented to us with an unknown primary. Now, whether or not we can find them in 85% of the time or not, how important it is to find it and resect it. Will it make a difference? Will it make a difference in a patient with multiple large liver mets? Will it make a difference in a patient with 1 or 2 liver mets? Do we need to find the primary? Do we need to resect it, and why? Who wants to answer that?
Sometimes yes, and sometimes no. If somebody's metastatic disease is overwhelming and the primary tumor is not causing any problems, and you're not really a surgical candidate anyway, there's no reason to go rushing off to surgery to take a little tiny tumor out of a small intestine that's a few millimeters across if you have 10 pounds of cancer in your liver. On the other hand, if you have a tumor you didn't even realize is already obstructing and it's halfway obstructed or 3/4 of the way obstructed, you may be better off getting that out before it obstructs all the way. And it can be done laparoscopically with a minimally invasive surgery. You might want to get it out sooner. And another issue is that if you're having surgery for any reason in the abdomen and the surgeon is able to see a primary that you didn't know you had, it's normally part of a standard good surgery to take out the primary at the same time you're in there anyway, just like it's normally fairly standard to take out the gallbladder while you're in there anyway, since half the time when people are on octreotide or lanreotide, they will get gallstones in their life, and if you're in there anyway, you take it out, even though you wouldn't specifically do surgery just to carve out a gallbladder. What does surgeons say?
I'm a little bit, I have a different take. Of course, I'm a surgeon. I like to promote surgery. The thing is, I look at the tumors, as I said, as a Bin Laden. And the Bin Laden, if you don't remove, he can always train another disciple and send out to somewhere else to do some harm. And one of the study, maybe I should complete, I noticed a few patients, after I removed the primary, somehow the liver metastasis becomes smaller. So I'm not sure, maybe I really do have a big research on this topic. Seems like maybe once you nail the Bin Laden, all of a sudden the disciple abroad become more scared, say, whoa, I'd better die down a little bit because someone just killed Bin Laden. And I have to come out with really a good, persuasive data on that one. Yeah, so far I don't have that. On the other side of the coin, Jim Howe's group and Rob Palmier in Oregon, they look at, say, how much patients will really benefit from if your disease burden reduced. The first study by Mayo Clinics, you need to have 90% debulk to benefit from it. They're based on Jim Howe and Rob Palmier, they say if surgeon can accomplish 75% of disease burden debulking, patient benefit from that. So based on that, we do promote to go in there. And especially for my personal bias, I think the reverse terrorist thing, the reverse pyramid I show you on the slide, I think you must find that this primary remove it if the patient is healthy enough to go through surgery.
I can't leave that alone. So the one, yes, if you find a primary and if you believe the primary is continuously shooting out micrometastases, then that's important. But the incidental or anecdotal report of metastatic lesions shrinking when you remove a primary, that's been reported before in kidney cancer, renal cell cancer, et cetera. And we don't really, I don't really hold much water to that. I don't know if Ed does either. But that may be due to a decrease in cytokines that are produced by the primary tumor. But in neuroendocrine tumors, if that happened at all, I'm not doubting you, I'm sure it happened, but it's anecdotal. If it happened at all, it may be to a decrease in serotonin production by the primary tumor, and you probably can get the same result with just using standard statin.
Or I just scare the tumor.
It could possibly be. The tumor looked at those dumplings and just didn't want to get GI distress. Barbara? If your Artria scan is negative, but we know you have tumor by MRIs, and you have responded to sandostatin in the past, so have the receptors regressed or have they changed, et cetera? Will your gallium-68 necessarily be negative, or could it still be positive?
No, we see all the time gallium scans being positive when Artria scans are negative.
That's why you're getting one on
It's
Friday.
so much more sensitive. If your tumors are not massive, they can very easily be missed on an Artria scan.
Okay, any other questions before lunch? Great, thank you guys.
Well, I want to thank our morning panel. It was certainly a very interesting session. Now, lunch is going to be downstairs near in the lobby. You'll see it as you look out over the nice railing that they have out there. But we'll meet you down there. We're going to go until about 5 to 1 and then take 5 minutes, come on back up here so we can get back in and get to work. Please take a look at the merchandise out by the registration table as you walk past for lunch, and thanks a lot.